Asked me to speak on secondary hypertension in 15 minutes. I said, you mean one? Or he said, no, cover as many causes as possible. I'm going to take 2 or 3 examples of patients that I have seen not long ago at Apollo, and I use those cases to illustrate how to do the workup for 2 or 3 types of secondary hypertension. So this is not going to be an all-inclusive tutorial. It is just going to be some quick highlights on when to suspect, how to do the workup, and how to manage patients with secondary hypertension. I have no conflict of interest for this presentation. In primary care, community practice, not the hospital, hypertension clinics, or cardiology clinics. Primary care practice, probably 5% of patients with hypertension could have a secondary cause. So how to separate this needle from the haystack, and that is a matter of clinical challenge, clinical judgment, discrimination, assessment, and follow-up. A vast majority of individuals have so-called primary hypertension, previously known as essential hypertension. But when you talk about specialty clinics, secondary hypertension could be 15, 20, 25, 30%. So I'll tell you now on some pearls on how to select patients for a workup. If you see a young patient with hypertension, by the way, none of the guidelines define what is young or youth. They only say young. So let us say age 25 or 30. If anybody has documented hypertension under the age of 25 to 30, you must think about the possibility of a secondary cause. I'm not going to say which secondary cause, but young patient with documented hypertension, please think about the possibility of a possible secondary hypertension in that patient. Now, let me go through so-called case-based approach to discover and manage secondary hypertension. This is a patient of mine who was seen at Apollo, as you see here, a few years ago. Her blood pressure was 190/116 on multiple medications. Age is 37, truly resistant hypertension, multiple medications. When you see a woman of that age with significant hypertension, one possibility is fibromuscular dysplasia or sometimes Stachys arteritis. So this is a patient who was seen by me, and I suspected she had secondary hypertension. She had fibromuscular dysplasia of both arteries and underwent angioplasty. And you will see here how the blood pressure has become normal within 1 month on no medications. So this is a classical case of young patient with hypertension with documented resistant hypertension. You think about the possibility of a secondary cause of hypertension. Now, what are the clues to suggest renovascular hypertension? Young women I mentioned to you might have fibromuscular dysplasia or Stachys arteritis. But in other age groups, it could be atherosclerotic renal artery stenosis. You have to make a distinction between atherosclerotic renal artery stenosis and non-atherosclerotic renal artery stenosis, because non-atherosclerotic renal artery stenosis are amenable to correction and usually curable, but atherosclerotic renal artery stenosis, even with a good procedure, the blood pressure might improve at the best, but cure is impossible. That is the reason why you have to make a distinction between atherosclerotic and non-atherosclerotic renal artery stenosis. By the way, renovascular hypertension is a retrospective diagnosis. It is not a prospective diagnosis. If somebody has renal artery stenosis, it does not mean patient has renovascular hypertension. The definition of renovascular hypertension is when you intervene with angioplasty or stent or surgery and the blood pressure comes down. That is renovascular hypertension. It is never a prospective diagnosis. Response to treatment defines the occurrence of renovascular hypertension. This is a patient with classical fibromuscular dysplasia, string of beads in the middle third of the renal arteries, and these kinds of lesions are amenable to angioplasty, and stent is usually not required, and if it is done properly, it might lead to cure. And think about the possibility, and I showed you one example like that before. Now, atherosclerotic renal artery stenosis usually is the extension of aortic atherosclerosis, and it is in the proximal part of the renal arteries, and if the patient has significant stenosis, something can be done, but one should not expect cure, some relief but not cure. In terms of screening, duplex Doppler is usually only useful for follow-up, but I would never use it for screening or diagnostic purposes. If the patient needs a follow-up, it can be done. As you can see here, this is a Doppler where the amplitude is slowed down and wide dispersion. After the correction of the renal artery stenosis, the amplitude is restored. So it's a pretty good procedure for follow-up, but not usually for diagnostic procedures. The question comes out, Dr. Ram, do you want to do CT or MRA? CT or MRA? For renal artery stenosis, CT angiogram appears to be much better than MRA for morphological diagnosis. When you see a patient with an abdominal CT who has got a small kidney and has hypertension, the other kidney is normal, one kidney is small, think about the possibility of renal artery stenosis as this is the case. This is now a only study that has ever been done to see if correction of renovascular hypertension with surgery, angioplasty, stent helps. As you can see here, there is no difference between chronic medical treatment and correction of atherosclerotic renal artery stenosis. So keep this in mind. This is a patient of mine seen again at Apollo. Young lady, significant hypertension. Look at the sodium, look at the potassium. So I have seen this patient for hypertension, but when I looked at the record, she always had hypokalemia, 1.8, 1.9, 2, 2.1. All the doctors said, eat fruits. Fruits will do nothing to correct hypokalemia. It's a supplement. You can't be eating fruits. It never corrects. So I saw that patient high sodium, slightly low potassium, high aldosterone, and low renin. And she had a CT scan, showed an adrenal tumor, and it was confirmed, and she had laparoscopic adrenalectomy. So ladies and gentlemen, now see here, significant hypertension before, hypokalemia. After correction of removal of the tumor, potassium 4.4, blood pressure completely normal on no treatment. So this is a curable form of hypertension. Look at aldosterone before and after adrenalectomy, renin activity before and after. So the features of primary hyperaldosteronism are unprovoked, de novo, spontaneous hypokalemia. Patient who is not on diuretics. If you have a patient with high blood pressure and low potassium, it is primary hyperaldosteronism unless proven otherwise. Make sure that patient is not on a diuretic. So what is the biochemical diagnosis of primary hyperaldosteronism? Low potassium, high normal sodium, high aldosterone, low renin. If the patient has aldosterone to renin ratio of more than 30, it's almost always primary hyperaldosteronism. Remember it. Aldosterone to renin ratio more than 30 is primary hyperaldosteronism. Keep that in mind. Now, people undergo workup for pheochromocytoma, and sometimes you don't find it. Most of the times you don't find it. But it can be very subtle, it can be very dramatic. This is a patient who was seen because she had slight palpitations, not much by the way, and slight sweating, not much. And the physician who was taking care of this patient called me, Dr. Ram, we have this VIP patient whose hypertension is not bad, but she has got a little bit of palpitation, a little bit sweating, and they did the workup in the hospital because very challenging, and she had an adrenal tumor. The question was what to do with this patient who is VIP patient. Then workup ultimately suggested that she had pheochromocytoma. And this pheochromocytoma was removed after preoperative treatment, and it was cured. She was cured of pheochromocytoma, and she lived for 35 to 40 years after the removal of pheochromocytoma, and she expired last year because of age. Rosalind Carter, Jimmy Carter's wife, she had a very small pheochromocytoma, but it was very, very dramatic. So majority of patients with pheochromocytoma have these symptoms. Majority of them, some might not have, keep that in mind. The question comes up, Dr. Ram, which is the best screening test for pheochromocytoma? Plasma metanephrine. If the plasma metanephrine is normal, the patient is unlikely to have pheochromocytoma. If the plasma metanephrine is high, then you do the workup. So ladies and gentlemen, not a very difficult test. Under any circumstances, in a sitting position, if you draw the blood for plasma catecholamines, and if it is normal, the pheochromocytoma possibility is quite small. Now, CT versus MRI for pheochromocytoma. CT is superior to MRI because it clearly delineates the tumor and there could be elements of necrosis. So a CT scan, by the way, after the biochemical diagnosis of pheo, not before. You have to make the biochemical diagnosis and then localization. In some centers, we have it here. If you suspect somebody with pheo and CT is negative, you might, if the MIBG is available, one can get an MIBG scan, and that's very good. But patient has to be prepared properly. And the last secondary form of hypertension that I'm going to discuss is obstructive sleep apnea, which was mentioned by Dr. Dayasagar Rao briefly. This is a patient, again at Apollo, severe hypertension and history of snoring, and apnea-hypopnea index is 36. Normally it is less than 5. So here you have a patient, significant hypertension and abnormal sleep pattern, and the apnea-hypopnea index is very high. So we recommended to the patient CPAP as much as possible. Nobody stays on this 100%. And as you can see here, after CPAP treatment, the blood pressure improved in this particular patient. So obstructive sleep apnea, the more and more obstructive sleep apnea the patient has, the greater likelihood the patient has hypertension. And studies have shown with proper utilization of CPAP, at least 50% of the time, the blood pressure is likely to improve if the patient is compliant with this. Now, 2 minutes, because Dr. Srinivas Kumar actually mentioned to say a few things about coarctation of the aorta. Coarctation of aorta is a congenital heart disease and usually occurs with other valvular problems also, but the patients could have significant blood pressure, at least in one arm. So when you suspect a person with a pulse weak on one side and the blood pressure is lower in one arm than the other, and the blood pressure is clearly lower in the legs, I don't think anybody takes blood pressure in the leg. I don't do most of the time, to be honest with you. But if you see disparity in blood pressures between arms and there is a gradient, arterial gradient between upper and lower extremity, you should think about coarctation of aorta. If somebody is still looking at chest x-rays, not many people look at chest x-rays anymore. If you find rib notching of some sort and the patient has hypertension and the rib notching is due to collateral vessels, and this can be a clue, not diagnostic, but clue to coarctation of the aorta. And initial test should be a CT angiogram to define anatomical coarctation of the aorta. So the blood pressure is elevated in the opposite arm, and the blood pressure is lower on the side where there is coarctation, and the blood pressure is lower in the legs. And now there are several treatments available. Actually, all of you are interventional cardiologists, you probably do this more. And stenting, angioplasty and stent implantation is supposed to be very helpful. Now, after you do the coarctation, surgical repair or non-surgical repair, the patients have to be followed periodically because they're at a high risk for accelerated atherosclerosis. So even in children, when you fix coarctation, you must follow the patients periodically because they're at a risk for future atherosclerosis. So Ajay, ladies and gentlemen, and Dr. Srinivas Kumar, in the time that was allocated to me, I covered salient features of selected forms of secondary hypertension, and if the patient is lucky, some forms are curable. If the patient is lucky, maybe it is better treated with appropriate medical treatment. With those remarks, I'll conclude. Thank you very much.